I'm Dr. Shreyash Gajjar working at Kokilaben Dhirubhai Ambani Hospital in Mumbai. This is a video technique demonstrating an all arthroscopic repair for ATFL injury to the ankle called the Arthrobrostrom repair. This is a 25-year-old who sustained a twisting injury to his right ankle playing football. He failed conservative management for almost a year, and his repeat MRI showed that the ATFL has not healed. And importantly, he continued to have ongoing symptoms of swelling, pain, and feeling of give way, and was unable to return back to playing football. As you can see here, these are his radiographs. There is no osteochondral lesions. The MR images confirm the ATFL tear and no healing. And on EUA, you can see on the left side how loose the ankle is compared to the normal right side. So surface anatomy is very important. And this is the medial malleolus, lateral malleolus. And you will see that the superficial peroneal nerve is also to be kept in mind. So these landmarks are very important. The fifth metatarsal subxyloid process and the adjoining line which corresponds to the extensor retinaculum. So through the anteromedial portal, a diagnostic arthroscopy is performed. In this situation, it was normal. And through the anterolateral portal, then, which is an outside-in portal, the distal fibula is prepared for the repair. And you can see here with the radiofrequency device, I'm clearing the distal fibula. This, again, fluoroscopy guidance is required to ensure accurate anchor placement. And once the distal fibula is cleared, you can see that we go for a point just proximal to the tip in the center. And through the dedicated sheath of the anchor, we first drill, in this case, a 3 millimeter bio anchor was used, a knotted type. And subsequently, that is tapped into the distal fibula. And these sutures are passed through the extensor retinaculum in an inside-out fashion. And then they are delivered out through lassos, as you can see on the skid, one by one, which ensures that these sutures are going through the extensor retinaculum tissue. And there is a bridge of tissue between two sutures. Subsequently, a second proximal anchor is passed. Again, it is confirmed on fluoroscopy. And that is just 0.5 to a centimeter proximal to prevent any blowout. And again, a biocomposite anchor is tapped in as seen here up to the laser mark, so that we know that the desired amount of anchor is within the bone. And this time, a different color suture to help in suture management is used. And that again, with the help of lassos, is brought out through the anterolateral portion. And the knots are subsequently tied. And that ensures that the extensor retinaculum double breasting happens, and that reconstitutes the ATFL. Once again, it's important that these knots, once tied, are buried underneath the subcutaneous tissue. And that is how it looks at the end of the procedure. That whole tissue has been brought in at the side of the ATFL, and there is hardly any room to cause any kind of distraction as was before we started. And that confirms the extent of stability. You can see on the video, it is extremely stable. Post-operatively, it's very important to immobilize the ankle in a plaster or a boot for at least 4 weeks, keep the patient non-weight bearing, and thereafter progressive weight bearing is commenced. Typically, range of motion exercises are also started, and at 3 months, strengthening exercises are commenced, and at 4 to 6 months, if objective assessment and patient symptoms are relieved, then return to sports can be contemplated.